This presentation is an introduction to shock and categories of shock as well as stages of shock. In this presentation, we'll just introduce the 4 categories of shock and review the common clinical manifestations that might be seen with each of those 4 categories. We'll also be going through the stages of shock just in general, and in class, we'll discuss nursing and collaborative care for patients with each type of shock. So before we break up shock into different categories or stages, let's review what shock is. So your Lewis text defines shock as a syndrome characterized by a decrease in tissue perfusion and an impaired cellular metabolism. So basically, the cells and the tissues are not getting the blood supply they need. The oxygen and nutrients and removal of waste that should be happening is reduced. The perfusion is greatly decreased. And we have hypoperfusion. Now that's a key word to understand with any type of shock. Anytime we talk about shock, hypoperfusion, not enough perfusion to the cells and to the tissues. So because the cells are not getting enough perfusion, their demand for perfusion isn't met with this supply of blood. This leads to what's called impaired cellular metabolism, where the cells are now forced to convert to anaerobic metabolism, and they end up producing lactic acid, which eventually leads to metabolic acidosis. So here's a brief overview of the stages of shock. Just keep in mind that different types of shock and different patients may progress through these stages more quickly or more slowly, and really depending on the patient's comorbidities and the type of shock, certain symptoms here may be more evident or less evident or even absent. But in general, these are the stages a patient will progress through in shock if no intervention is taken. So let's take a look. So in stage 1, we're talking about the very beginnings of this hypoperfusion. So it's happening on a cellular level. Less oxygen is getting to the tissues, but we can't really tell just by looking at our patients. Those clinical indicators are not evident to us yet because shock is just initiating and just happening on this small scale. Now in stage 2, shock is progressing and the hypoperfusion is more notable. So this is where you, as the nurse, are starting to notice some abnormalities in your patient. The body will begin to go into emergency mode. It's trying to compensate in every way it can for this hypoperfusion that it's sensing. So our baroreceptors will sense this hypoperfusion and activate the sympathetic nervous system, which releases epinephrine and norepinephrine, and that's going to cause tachycardia and systemic vasoconstriction because we're worried about perfusion, so we need to get that blood to where it needs to go. And the sympathetic nervous system also causes our heart to beat stronger. It increases that contractility. And all of this sounds great. We're compensating. But one thing to remember, when we go into this emergency sympathetic response mode or in this compensatory stage, we're asking a lot more of the body. And when we ask a lot more of the body, what does that body need? It needs good perfusion. So you can see how this could lead to a vicious cycle. In order to compensate for hypoperfusion, we actually need good perfusion. So in stage 3, or what's called the progressive stage, this is basically where all of these compensatory mechanisms are failing. Our patient's mental status begins to really change. That's one really notable thing about stage 3, or this progressive stage. Maybe now they're lethargic or potentially stuporous. So we start to see the impact of that hypoperfusion on their neurological status. And we also see severe capillary permeability. So it allows all that fluid to leak out of the vasculature and into the interstitial space. And it can possibly cause anasarca, which is this diffuse, profound edema. And because all of those compensatory mechanisms are failing, we also begin to see signs of organ failure. So depending on the organ, our symptoms might be oliguria or alveolar edema or low cardiac output or jaundice if they have liver failure. So in this final stage called the irreversible stage, the name kind of gives you a hint as to what's going on. The patient is very unlikely to recover from this shock. Their blood pressure is extremely low. They are severely hypoxic. And we're noting that multiple organs are failing and the body's compensatory mechanisms really can't handle all of this. So you can see how it's essential as we look through all these stages, we need to identify shock early on. As we move through these stages from 1 to 2 to 3 to 4, it becomes more and more difficult to reverse shock and our patient becomes less and less likely to recover. So shock is hypoperfusion, which causes impaired cellular metabolism. And unfortunately, there's quite a few different ways a patient can experience hypoperfusion. And we divide these many different causes of hypoperfusion in 4 larger categories. We have hypovolemic shock, cardiogenic shock, distributive shock, and obstructive shock. So remember, regardless of which type of shock we're talking about, we're always talking about hypoperfused cells. So the causes of shock will vary, but the response of those cells is very similar because hypoperfusion is happening. So it's important for you to not only identify the cause of shock, is it cardiogenic, hypovolemic, etc., but it's also important that you can recognize hypoperfusion. So what are those signs of hypoperfusion? So pause the slide for a second and think of at least 5 signs of hypoperfusion that you could assess as the nurse. So here are just a few signs of hypoperfusion. You'll note that some of these signs are early signs and some are later signs of hypoperfusion. For example, cyanosis is not going to happen right away. It's a much later sign of hypoperfusion. But fatigue might be an earlier sign. Now, because our kidneys are not getting perfused, we see a lower urinary output. Our peripheral pulses and capillary refill will be decreased. The skin will be cold or clammy because those compensatory mechanisms might be shunting or directing the blood to a more important area of the body, like the core, the vital organs. A key sign of hypoperfusion is our patient's level of consciousness and their behavior. So a patient might initially be anxious or agitated, and then later they might become lethargic or even comatose. So let's begin with our first category, hypovolemic shock. And this is often one of the more simple types of shock to understand because we're just talking about hypoperfusion because we're low on blood or we're low on intravascular volume. Notice I didn't say low on volume, it's intravascular volume. And that being said, some patients have what's called absolute hypovolemia because they've simply lost a lot of fluid like a hemorrhage or vomiting or diarrhea. However, some patients can have what's called relative hypovolemia, and that's where we didn't really see any massive blood loss or massive amounts of fluids lost through the GI tract, but the fluids in the vessels has shifted out of the vessels and into the tissues, that third spacing. So the total amount of fluid in our patient's body didn't really change, but it's not in the vessels. The fluid in our patient's body has shifted out of the vessels and into the tissues, so now we have less fluid to send to the heart and pump out of the heart. Now, depending on the amount of intravascular fluid the patient loses, our patients may have different responses. So for example, if the blood volume is only reduced by up to 15%, the body can compensate fairly effectively and may recover on their own even. Now, when blood loss is between 15 and 30%, now we start to see activation of the sympathetic nervous system. So one of the key signs of that is the heart rate increasing. The peripheral pulses will constrict to divert that blood to the core. Contractility of the heart will increase, etc. However, if we start to look at a patient who's lost over 30% or even over 40% of their blood volume, these patients are not able to compensate as well and maybe not at all. So ultimately, the tissue is destroyed because of that severe hypoperfusion. So what will these patients with hypovolemic shock look like? What are their clinical manifestations? Well, let's say you're caring for a patient who has a GI bleed. So she's just had 7 bowel movements that were frank red blood. So what will she look like? Initially, you might see some anxiety or restlessness, tachypnea, her respiratory rate will be up. Sometimes patients in severe shock will even have this sense of impending doom. And in a sense, you look at them and they have this fear in their eyes. Their body knows something really bad is going on. So one of the cardinal signs of hypovolemic shock is hypotension with tachycardia. Now, as hypovolemic shock progresses, we may see changes in her level of consciousness. So what do you think her hemodynamics will look like? Let's pretend she has a pulmonary artery catheter and an arterial line in place, and we can measure all of these parameters. Pause the presentation and see if you can guess what each of these parameters would be, high or low. So here you can see we have a patient with low intravascular volume. That's hypovolemic shock. So how do we measure intravascular volume? How much blood is returning to the heart? So preload would be low. So our CVP and our PAWP, or wedge pressure, will be low. That's an indicator of our intravascular volume. Now, when we look at stroke volume and cardiac output and cardiac index, all of these relate to how much blood is going to be pumped out of the heart. And this will typically be low because we have a limited volume coming in. So why is the systemic vascular resistance high? Well, remember, our sympathetic nervous system wants to shunt the blood and direct it to our vital organs. So it directs the blood away from our peripheral vasculature and to our core, causing vasoconstriction. That is going to increase our systemic vascular resistance. Here you can see some of these measures we just talked about in a table. So we're going to use this table to compare the different types of shock and recognize the similarities and differences between each. So we've talked about hypovolemic shock. Our next category is cardiogenic shock. So now the hypoperfusion is not being caused by a low intravascular volume like with our hypovolemic shock. It's being caused by a bad pump. Our heart is not pumping out sufficient blood for our tissues. So this is typically due to systolic dysfunction, or that squeezing dysfunction, a bad squeeze, bad contractility. But it can also be caused by diastolic dysfunction, where a heart doesn't fill up with blood appropriately. So what would cause cardiogenic shock? What would cause this bad pump? Well, we've got a heart muscle problem. So an acute myocardial infarction is going to injure our myocardium, that heart muscle. And it is the most common cause for cardiogenic shock. So think about this. If you're taking care of a patient who has just had an MI, your first thought should be, this patient is at high risk for cardiogenic shock. This is the #1 cause for cardiogenic shock. However, other patients such as those who suffered a blunt chest trauma, that can cause a cardiac injury, or even somebody with severe valvular stenosis, that could lead to a low cardiac output because the heart is working up against that really stenosed valve and it starts to get fatigued, causing poor contractility and a bad pump. So note that cardiogenic shock has a very high mortality rate, and thus the nurse's early detection and rapid intervention and collaboration with the healthcare team, that can make a big difference on the outcome for this patient. Now, what would this patient look like? This patient with cardiogenic shock, they have a bad pump. So they're either not filling or not pumping effectively. And sometimes it's easiest to think of a patient with heart failure and how they present. So if they have left ventricular systolic dysfunction, that left ventricle is not pumping effectively, the fluid's going to back up into the lungs. So we'll hear crackles, or maybe our patient will have tachypnea or labored breathing. And because our heart is not pumping effectively, that will lead to a low blood pressure and a narrow pulse pressure. So there's not going to be as big of a difference between when the heart is relaxed or squeezing. The diastolic and systolic pressures start to get closer and closer together because our pump is not really making that big of a difference from when it was relaxed. So let's see if you can think of some signs of hypoperfusion that we discussed earlier. So what might your patient have due to just general hypoperfusion and it happens to be caused by a bad pump? Pause the presentation and see if you can come up with some of these. So remember, we have poor tissue perfusion. So we could see pallor or even cyanosis if it's progressed. We'll see decreased urine output, weak pulses, delayed capillary refill, cool, clammy skin, and those potential changes in levels of consciousness. Now, take a look at these hemodynamic values. What do you think these will be in a patient with cardiogenic shock, high or low? Pause the presentation again and see if you can determine which of these will be high or low. So you can see automatically we have a bad pump, so our cardiac output and cardiac index will be low. Now thinking about heart failure, a bad pump leaves fluid behind. So our preloads will be high, our CVP and wedge pressures. Oftentimes the pulmonary vascular resistance will also be high, and again, this is from fluid backing up from the left atrium. So here again, you can see those values on our table. Now notice the differences in hemodynamics between hypovolemic and cardiogenic shock. Take a second to look through these and see why certain ones might be high or low. So moving to our next category of shock, let's look at distributive shock. Now there are 3 subtypes of distributive shock, but they're all put in this category of distributive shock because they all cause massive vasodilation. In some way, shape, or form, each of these subtypes, neurogenic, anaphylactic, or septic shock, they'll all cause the vessels to dilate. Now you can see what happens when a container gets bigger but the volume stays the same. So our vessels are dilating but the amount of blood didn't change. So suddenly the pressure in that container in that blood vessel is going to drop. And not only does this lead to hypoperfusion and hypotension, but we also see poor venous return to the heart. All the blood starts to pool in the periphery in these big dilated vessels, and it doesn't get back to the heart as quickly and efficiently as it would in our nice, more constricted vessel. Now, the first type of distributive shock we'll talk about is neurogenic shock. And you might recall learning about neurogenic shock before in patients with spinal cord injury. And note that there's a difference here between spinal shock and neurogenic shock. These can happen in the same patient who had a spinal cord injury of T5 and above, but these are different problems. So neurogenic shock, with neurogenic shock, the key concept to remember is that the sympathetic nervous system, our fight or flight response, has been interrupted. So think of the opposite of the sympathetic response, our parasympathetic system. So rather than shunting blood to our core and to our vital organs and seeing tachycardia, we see vasodilation. And that's why this falls into distributive shock, this massive vasodilation. Now, normally, when we see a blood pressure of, say, 90/40 that we see here, our bodies would respond with a sympathetic response, tachycardia, increased contractility, etc. That's our sympathetic response to hypotension. However, remember what caused this massive vasodilation and this hypotension. We've knocked out our sympathetic response. So instead, we actually see bradycardia, and this is one of the cardinal signs of neurogenic shock, hypotension with bradycardia. Now, what might we see in a patient who has neurogenic shock? Let's say you're taking care of a patient who was just ejected from a vehicle in a motor vehicle crash. He's suffered a C4 spinal cord injury. He's in neurogenic shock, he's vasodilating, and his sympathetic nervous system is not kicking in. So because of that massive vasodilation, we don't see one of our cardinal signs of hypoperfusion, that cold, clammy skin. We actually see warmer skin. Remember, vasodilation allows blood to pool in the periphery, so it'll actually warm their skin up. Now, these patients may also experience poor control of body temperature because of a head injury. So they may eventually have what's called poikilothermia. And this is basically when the body adapts to the temperature of the environment. So think of a cold-blooded animal, for instance. Now, thinking more about neurological injury, we may also see bladder or bowel dysfunction. We might see spinal shock as well as neurogenic shock, so some flaccid paralysis below that level of the lesion. So these patients are in some ways going to present somewhat differently than our other patients with other categories of shock. So now take a minute again to guess what our vital signs and hemodynamics might be in a patient with neurogenic shock. Pause the presentation and consider your answer. So these are all low. Now think about it. Why are each of these typically high? It would be in a sympathetic nervous response. So since the sympathetic nervous system is interrupted, we see the opposite. And remember that cardinal sign of neurogenic shock is bradycardia with hypotension. Our next type of distributive shock is anaphylactic shock. And in this case, our hypoperfusion is still being caused by massive vasodilation, but this is because the body is having a severe, exaggerated response to an antigen. So remember, local vasodilation and capillary permeability are normal at an injury site or an infected area, but in anaphylactic shock, we see massive vasodilation and capillary permeability on a larger scale. So not only do we have hypotension due to this growing container with the same amount of blood, these dilated vessels, we also have hypotension because those vessels are leaking. The capillaries are allowing fluid to leave the vessels as well. Now, another common sign you'll see in a patient with anaphylactic shock is angioedema or facial swelling, facial edema. And not only is this probably embarrassing and scary for the patient, but remember what is kept on your face, your mouth and your nose. The airway is closing up. So not only do we have hypotension developing, but we have an airway closing as well. So even more, anaphylactic shock happens pretty suddenly. So again, this is where your nursing assessment is critical. You'll likely be the one at the bedside or in the emergency department that notices these signs, and it's up to you to communicate this to the healthcare team immediately. So now what will these patients look like? Well, aside from this angioedema, we may hear signs that their airway is closing. So stridor, wheezing, even chest pain. They may also have flushed skin, and you can imagine how anxious these patients must feel. So thinking about what happens in anaphylactic shock, what do you think this patient's hemodynamics will look like? Pause the presentation and consider which one of these will be high or low. So you can see all of the values that are low here, just like in neurogenic shock with that vasodilation. But our sympathetic nervous system is still intact. So this patient still has the ability to compensate with a fast heart rate. This massive vasodilation is still going to cause a low SVR and poor venous return to the heart, so that's going to cause a low CVP, and that's going to lead to poor cardiac output and poor cardiac index. Now moving to our third subcategory of distributive shock, this is septic shock. Now this hypoperfusion is still caused by massive vasodilation because it's a distributive shock, but instead of the cause being a spinal cord injury or an exaggerated response to an antigen, it's now due to an exaggerated inflammatory response to a systemic infection, so sepsis. Now it's important to differentiate between sepsis and septic shock. So not all sepsis actually becomes septic shock. Sepsis is simply a systemic response to a suspected infection, a bloodstream infection. And it becomes septic shock when we start to see hypotension with sepsis. And that hypotension is pretty stubborn, so it persists even if we give our patient IV fluids. It's refractory to fluid resuscitation. Now, the most common cause of septic shock is a gram-negative or gram-positive bacterial infection, but the cause can vary outside of these. Now, the systemic response to this infection will cause an inflammatory response throughout the body, and that includes massive vasodilation. But we also see that capillary permeability again, that leaking out of the contents from the capillaries. Now, let's take a look at what is leaking out. So we have cytokines and all of those pro-inflammatory mediators which actually trigger the clotting cascade. So this is going to cause development of little microclots that actually plug up perfusion to organs in a sense. So our organs are not getting perfused as well because of microclots and also because of just plain hypoperfusion from shock. So also released is what's called tumor necrosis factor and interleukin-1. And it's theorized that these mediators actually cause myocardial dysfunction. So with septic shock, we have a lot going on. We have vasodilation, capillary permeability, and myocardial suppression. And all of these are going to cause hypoperfusion. So now when we look at this complex patient with septic shock, what might we see? Well, it's important to recognize that septic shock has two major phases. And these kind of coincide with the stages that we discussed at the beginning of this presentation. So essentially, the early phase is the body trying to compensate, and the later phase is the body being overwhelmed and no longer able to compensate. So early septic shock, and sometimes we call this warm sepsis, we see all these signs of the sympathetic nervous response. The patient's tachycardic, their heart is pumping faster, it's pumping stronger, they're breathing quickly and deeply. And that quick, deep breathing actually can cause respiratory alkalosis. They're flushed, they're agitated, they're potentially confused. So because they're compensating in this early phase, their blood pressure may not even be dramatically low. They may be sustaining all of these compensatory mechanisms pretty well. And we often see a fever, even a low-grade fever, during this warm phase. So just like when we discussed the stages of shock, we want to intervene in this early septic shock phase. If we catch it here in this warm sepsis, warm septic shock, and identify that yes, this patient has septic shock in this early phase, this patient has a much better chance of survival. Now in late septic shock, think of that progressive or even irreversible stage of shock, and sometimes we call this cold septic shock. And we've exhausted all of our resources. We no longer see warm tachypnic patients. We see a colder patient. And sometimes their body temperature is pretty far below normal, even if they have an infection. This patient might be breathing too slowly and shallowly from exhaustion. So we start to see acidosis. That's our respiratory acidosis. But we can even see mixed acidosis because the patient's cells are hypoperfused and now in anaerobic metabolism, producing lactic acid. Now, our patient isn't as agitated. They're now very lethargic and maybe even unresponsive or comatose. So remember, in these later stages of shock, patients start to suffer from multiple organ failure. And one of the common signs we often see from septic shock is ARDS. Remember, this involves capillary permeability as well, so the fluid is shifting into the alveoli. Now, considering all of this, what will our patient in septic shock look like if we could measure all of these hemodynamic parameters as well as their heart rate? Pause the presentation and consider your answer. So you can see that regardless of the type of shock, our blood pressure is going to be low. We have hypoperfusion, and in this case due to vasodilation. Now that vasodilation also means that our SVR will be low, and our sympathetic nervous response is still intact, so that heart rate will probably be high, especially in those early stages. Now the stroke volume and cardiac output and cardiac index are typically low, but there's a little up arrow here for what might happen in warm sepsis. So that sympathetic nervous response might be so effective at first that the stroke volume, cardiac output, and cardiac index are actually a little bit increased. But later on, as the patient progresses and they decompensate, that cardiac output and index and stroke volume, all of that will begin to decrease and cause more hypoperfusion. So moving from distributive shocks, let's review our last category, obstructive shock. So here we will still be referring to hypoperfusion, but this hypoperfusion is caused by an actual obstruction of blood flow, and it's not allowing the heart to fill up with blood, which, as you remember, is a very important thing. When you're pumping blood out, you need something coming in. So nothing coming in, nothing going out of the heart. So what might cause this obstructive shock? Well, some common examples are problems that push on the heart. So for instance, a pericardial tamponade, or when the pericardial sac is filling up with so much fluid that it compresses on the heart. Or maybe a tension pneumothorax, which also puts a lot of pressure on the heart. So it's hard to fill up a compressed heart. Now, another potential cause of obstructive shock is what's called intra-abdominal hypertension that eventually leads to abdominal compartment syndrome. So intra-abdominal hypertension is basically very high pressure in the abdominal cavity. And maybe somebody has bowel disease or an intra-abdominal infection that causes a lot of pressure on the abdominal contents. And all of this compression is happening in a container, the abdomen. So that container can only take so much pressure, and just like somebody can get compartment syndrome from a swollen leg in a cast, they can actually get compartment syndrome in a very high pressure belly. So why would this cause obstructive shock? Well, while we're compressing all of those abdominal contents, look at what else we're compressing. That venous return to the heart. So that blood flow is getting obstructed. Now, aside from the many signs of hypoperfusion that we've discussed, these patients will also often present with a lot of anxiety. Obstructive shock can happen quite quickly. And again, the patient's body senses that something really bad is happening. And they may have this panicked look of fear in their eyes and on their face, and they may be very anxious or even agitated. Now, also because of all of this pressure preventing blood from returning to the heart, we may see jugular venous distension, or JVD. So blood that should be going to the heart is starting to back up into the neck veins instead. So these patients will also often present with shortness of breath as well. Now, what do you think our hemodynamic parameters will look like in this patient? So take a look at these three. Will they be high or low? Pause the presentation and consider your answer. They're all low. If we aren't filling up the heart with blood, our preload will be low, our CVP and our wedge pressure. And if we don't fill up the heart, then we won't have much to pump out, so our cardiac output and cardiac index will be low. Here we have a final table with all of the hemodynamic measures for different categories of shock. What do you notice? Remember, no matter what causes the shock, we will have hypoperfusion and impaired cellular metabolism. So the blood pressure will always be low. Also, as we mentioned with neurogenic shock, the sympathetic nervous system is blocked, so all of our parameters for neurogenic shock are low as well. So take some time to look over this. Feel free to pause the presentation and see if you can quiz yourself on why each one is high or low.